The second part.
So it's the fourth part which is the least.
Second part.
You're all guessing.
The second.
It's the first part.
First.
That's why you get perforation later. The second part has segmental blood supply. Fourth part starts getting the jejunal supply. Some branch, you must have seen during Vipul when we were ligating, the celiac axis gives branches to the fourth part. So fourth part is not a problem. It is usually the first part, and therefore it's unusual. So what's the etiology here?
So there was
I'm asking you what's the possibility here.
It can be Zollinger-Ellison syndrome.
Zollinger-Ellison syndrome. What is that?
Sir, because of the heterotropic, because of the increase in the gastrin secretion, there is increased HCl secretion, which causes multiple intractable ulcers in the small bowel, sir.
Why do you say it is not possible? Why are you saying it's not possible?
it is not possible.
Why? When a ghost? Is a question that will be asked.
So it could be Wilkie syndrome, sir.
Wilkie syndrome. What is Wilkie syndrome?
So when the duodenal third part gets obstructed between the SMA and the aorta, happens in young females.
Mesenteric arteries.
SMA
Syndrome.
Loss of
Man, we are talking about the ulcer. You thought you'll mention a syndrome and get away with it?
It doesn't cause it perforation, it just causes
obstruction.
What is Wilkie?
So Milwaukee, I mean Wilkie cast syndrome.
Yes, don't speak loudly.
Sir, cast syndrome because of putting cast around the abdomen. The superior mesenteric artery will be compressed between.
Cast syndrome won't be the case, you know. Wilkie, the artery of Wilkie is an end artery supplying the first part of duodenum. A lot of people used to have an ischemic theory for peptic ulcer earlier. And they thought this is the cause why first part gets it more commonly. So it was thought so. But today we know H. pylori is there. But why H. pylori produces it? How does it produce it? Those are beyond your discussion here. But fourth part is rare. Is it possible that it was iatrogenic?
So there was no perforation of the duodenum. So it was on the fundus of the stomach only.
Oh, so they reported fourth part.
Yes, sir.
Yes, sir.
So how could they confuse fourth part with stomach?
So even Ayush went to discuss with the radiology, but they got offended with the.
And how are they offended, sir?
Sir, I just asked them whether because intraoperatively we found us perforation in the fundus of the stomach, and that given perforation in the duodenum. So they just said we cannot identify the perforation on a CT. We just told you there is extraluminal and intraperitoneal free.
Remember this is a message to be taken home. You don't treat the CT, treat the patient. And CT is not a gold standard. So all those people who have taken protocols where CT is a gold standard, they are doing a mistake. Because operative findings are the gold standard, and in fact if you send it for histopathology is the gold standard. None of this is the gold standard. Cerebral palsy and this presentation, is there any connection? Why the gastric perforation? Why is gastric perforation rare, Aman?
So because of the rich arterial blood supply of the stomach. Stomach has a good blood supply.
Speak loudly.
So the blood supply of the stomach is
Okay.
apart from good arterial supply of the stomach, so there is no other. I don't know, sir, any other reason.
Sir, barrier function of the stomach is also present with HCl.
What is the barrier function of stomach? That's correct.
Sir, it occurs in layers. In the first layer there is mucus with
No, otherwise you are asked the question very commonly. Why doesn't the acid in the stomach digest stomach itself? Because of this barrier system. The mucosa is such a thick barrier that it won't percolate through or it won't permeate through. So it's not common. So to get it would indicate what? And immunocompromised status, anemic patient, poor blood supply, and some underlying pathology. Anything to do with cerebral palsy? What medication is he on?
She is not on any medication, sir.
they also do tend to have pylorospasm more commonly. That can be a factor. Talking bullshit.
Yes, sir. So we can repair the fundus, sir, primarily, as the stomach has good pressure.
Manshu,
So we can
if you are saying the same thing, say the same. That's all.
And the NG should be first beyond the perforation. For
In the stomach beyond where will it go?
If because the perforation size is small, sir, and the blood supply is good, we can do primary repair, sir.
Also, we are
No, none of you talked about the
Sir,
patient.
yes, and sir, if the Apache is also good. Sir, if
We
Apache
are
is
just talking about the bloody perforation.
If the patient is stable and hemoglobin levels are within normal limits, and if we are suspecting that there is gastric atony, then even gastrectomy can be done, sir.
sir, if Apache is bad, Apache is bad, we can do gastrostomy.
Gastric perforation. It's a good idea there.
Gastrostomy can be done, sir, if Apache is good.
Bad Apache do a gastrostomy, bad stomach do a gastrostomy, because nasogastric tube doesn't decompress the stomach that well. You can freshen the edges and make it into a gastrostomy. You use, what are the types of gastrostomy? Find the example. You should answer that 1, 2, 3. Witzel and
Stammer.
stam. So which one is preferred?
Sir, Witzel.
Stomach.
Stomach, sir. Sir, Witzel is preferred. We make a tunnel, sir, and then
Very good. You make a tunnel. How do you make it?
subserosal.
That's the stomach. That's the perforation. Freshen the edges. Apply a pursing. Okay. And if you are doing, this is for the stem, 2-layer pursing and bury it. अबे क्या है? No problem there. No problem. Can I do it now? So we prepare a seromuscular flap with it. It comes out to the anterior wall. Close the other. Wrap. So this is the flap. The tube is inside it. And then you close it. It becomes a tunnel, and this is an anastomos to the suture to the skin. So that would be with the, that would serve as a more reliable, and mostly we don't do Witzel. The reason being, it becomes kind of a permanent opening. The Witzel is done when you're doing it for cancer, and you're not going to use that stomach. For perforation you can do a stam gastrostomy, and whatever you have, the terms that you're using in jejunum, it's an extrapolation of this only. You don't do Witzel in jejunum because it will get very narrow. So we do stam mostly. But with stam we tend to prepare a seromuscular tunnel which achieves the same purpose, but that narrows it down. So in jejunum you need to fix it better. So fix it very well. What is he getting, sister?
running fever, so we have updated one like this. Post of day 25 of laparoscopy done in case of perforated peritonitis. Now, sir, it's been 5 days. Patient is in obstruction, sir. So we have given one gastrography
I had
challenge.
not expected from you. You gave me such an incomplete statement. Repeat what you said.
Post of day 25 of laparotomy done in view of perforation peritonitis. Improperly there was a perforation which was
What was the score?
Apache 2.
Why don't you say that? How can I accept it? All over आपको मेरे साथ. Without mentioning the score, don't give it. The same old crap when you just did this, you did that. So what was done?
So stoma was made, sir. Then patient was doing well, sir. She was.
Can you see the peristalsis of the bowel? You're doing fine, and this is, what is this called? What is this called?
Wound manager.
Wound manager. And this is a burst abdomen, we have to manage it as an open abdomen. It's still a prostomy. So what is it now?
Sir, it's been 5 days, sir. The stoma is not yet not functional.
I
sir.
think the bowel is moving. There's a bit of dilatation. I don't
Right.
think she'll require reoperation. That's the question you were asking.
Yes, sir.
You can't do CT in this patient, so what is it that you can do? Urograph in contrast.
Sir,
study.
we have given one.
So what does it show?
Sir, actually, sir, there is intracranial fistula also, which we cannot make out from where the bile is coming. The contrast, it came out through the perforation side, sir.
It is just proximal to ileostomy.
Yeah, proximal to elbow.
So this could be the possibility. No? This could be the.
So the stoma won't work if there is a proximal leak.
Stoma.
So can we catheterize that? Can we bring that out? Can we refashion at bedside?
Sir, actually, we cannot make it.
It's not visible to you.
Yes.
Huh? But when the patient is under anesthesia, maybe you can do that. So that's the only thing you're going to do. Otherwise, she'll lose a lot.
Yes, sir.
The stoma is also retracted. Sir.
Slightly.
I hope it is not that retracted stoma which is causing
No,
the
no,
leak.
sir. It is not.
It is
No, sir. There was a clear
before the
perforation
notice was
proximal to the ileostomy.
How far proximal?
So it was just below the abdominal wall. So maybe around from the stoma it was hardly 2 centimeters,
So I think that can be
2-3
negotiated.
centimeters.
Take it up for a bedside under sedation leak.
Sedation. Okay, sir. Sir, with got rupture in the right side pleural cavity. Patient was managed with right-sided ICD incision, and also patient had a right-sided picture catheter which was placed outside in another setup. Sir. Patient when he right now, sir, the ICD is running only serious fluid, sir. It's been more than 5 days. Nearly 100 to 50 to 100 ml serious fluid is running, sir. Sir, and the X-ray, the current scan, it showed the loculated collection, which is serious only. So we had taken one respiratory medicine, opinion, sir. They have asked if the output is less than 50 ml for 3 consecutive days, then clamp it for 24 hours and get one ultrasound thorax done. After that, they will review. Today, sir, his ultrasound is planned for.
So this is a rupture of liver abscess into the pleural space.
Yes.
So why should you need their advice? What are the, this will be an empyema.
Right.
So how do you manage empyema? Diamenic?
Sir,
What is acute, what is subacute, what is chronic?
according to duration of the duration, sir, chronic is when it is more than 6 weeks or 2 months,
Right, right.
and subacute is when it is between
6 days, 6 weeks, 6 months. And what do you do for acute? Aspiration.
acute.
For subacute?
Antibiotic
Intercostal drainage.
chest.
And maybe resection of the rib and open drainage as they call it. And for chronic you have to do decortication.
Surgical
What is decortication? Removal of the pleura of that side. Now this has been replaced to a degree by VATS. You can do minimal invasive procedures. And using a laparoscope, Mandeep was here when I did VATS for 2 patients. One was in ICU, that mentally retarded child who finally was discharged. We went on the left side, we removed all the pleura. It's possible to do it. Under short anesthesia it was possible and patient had complete recovery. So remarkable results you get. The only challenge in decortication in patients with tuberculosis is that it's stuck very badly, so there are lots of blood vessels, it may bleed a lot. You leave a chest tube there, it settles. Is he by any chance an alcoholic?
He was.
You should have again given me the complete story of falling short of it. It's a known alcoholic with a
Yes.
liver abscess which is ruptured into the pleural space, and has it ruptured into the peritoneal cavity also?
No, sir, no.
So why does it take that route?
So because of lymphatic channels through the diaphragmatic ports, stomatas.
It's not direct perforation, it's lymphatic. You are right. 1000 ग्राम? 1000 हुआ ना?
200
ये 1000 ग्राम कुछ होगा, 2000 ग्राम भी होगा फिर. 1000 milligram. One bottle. तो 1000 क्यों चाहिए होता है?
So double dose metrozil we give for.
But double dose is 800.
Oral.
You shouldn't mention 800. You should have आपने कहा ना 800 है. So why 1000?
So in the bottle, the dose is 500 mg, not 400 mg. So
It's 400 mg.
it's 100 ml and 500 mg.
You always the saline bottle has 540 ml, not 500. What is that 40 ml for? It's a loss in the tubing. It's a loss in the.
So 54-year gentleman, no
ठीक है
case of
आप?
carcinoma left breast, sir. Clinically, it's T3, N1, N0.
There are two options. Either we do it tomorrow or otherwise day after tomorrow. When it will be done. High octectomy, mastectomy can be done in emergency. I'll come and do it. Otherwise tomorrow put it in the list.
Sir, his hypertension, sir. They have
आपका
got
ब्लड
one
प्रेशर का
level, sir. If it
प्रॉब्लम
is
है तो
stable,
दवाई ले रहे हैं आपकी नहीं?
बीपी की दवाई है, ब्लड प्रेशर कोई प्रॉब्लम नहीं है।
कोई प्रॉब्लम नहीं, ये नहीं हो रही है प्रॉब्लम। ये ले लेंगे दवाई ठीक हो जाएगी। इन्हें पता ही नहीं इनको ब्लड प्रेशर की प्रॉब्लम है। आप गोली नहीं खा रहे कोई ब्लड प्रेशर की?
जी सर, नहीं खा
So when you don't take any medicine and you don't know about it, you will live longer. Okay, knowing about it can also be a problem. But he has to be fit now.
Let's just ask for cardiology opinion, then it's the cardiologist. He has taken it, sir, but he does not have the cardiology opinion.
Now the core biopsy report is DCIS.
Yes, sir. Yes, sir.
Then start with 5 years only. What should we do? Male cancer, DCIS.
Sir, surgical option should be started from, and it is preferable to check for any lump that is present or not, and
Lump is
ultrasound.
present?
Sir.
Can you show it? Take it
For this
in the picture.
Sir, this
Why
is
go far?
from biopsy. It may be wrong, wrongly false negative.
Describe it.
Sir, on
Clearly there is a left-sided breast mass.
on inspection.
The skin doesn't look involved. The nipple areola complex is widened. The left side is higher. I mean the level is almost the same, but it is wider. NAC is wider here than there. So clearly the mass is pushing,
Skin is
and the skin is shiny. It's about to give way. So what is the stage? Clinical stage.
Sir, it is T3, sir, because there is no body arrange, no ulceration or no satellite nodules.
Demonstrate fixity to the chest wall.
कमर में रखो बस, कुछ नहीं करना है, ठीक है? First I am checking.
Relax pec major.
The pectoralis major is relaxed. I should have come on the right side.
Doesn't matter.
Now I'll check the fixity along perpendicular to the tendon of the pectoralis major and
This is perpendicular. that is-
perpendicular to the pectoralis major tendon and along the tendon. Now Baba,
It's not fixed to
it
anything.
is not fixed to the
जोर
pectoralis
से
major.
दबाओ.
जोर से दबाओ हाथ. Now
Zero.
pectoralis major is
Check
fixed.
that it is taut.
Taut. There is no restricted
But it is
mobility
going beyond the pec major. So how would you test for fixity to serratus simply?
Now I will also ask the patient to
Okay.
to forward.
आगे झुक जाए.
बस सामने झुक जाओ.
It is falling
ये छोड़
forward.
दो.
So it's not fixed to chest wall.
Chest wall.
But how do you look for serratus?
I will come. I will go near the wall of the examination hall and ask the patient. I will stand in front of the patient and
And
ask the
press
patient to
it.
press my shoulder.
This is it, and core biopsy is DCIS. Now, examine the axilla. Correct way of doing it.
I will keep the hand of the patient over my left hand only and ask him to relax. मेरे हाथ में रख दो.
Now it will relax. Do you find the notes?
Sir, in the central group.
There is one note. So what is the clinical stage?
It is T3, N1 and M0. No symptomatic.
Make it better.
Clinic CT3
CT3 and
Even that is not correct.
55 years.
55-year gentleman with left-sided carcinoma of breast, clinically T3 N1 M0.
Even clinical requires ultrasound these days. So there is nothing like clinical stage. There is no N1 without ultrasound. Am I correct? Yes. AJCC accreditation, is that clear?
Yes.
So the clinical staging of axilla involves doing an ultrasound of the axilla. You have not done it, so what would you say? What would be your answer? My clinical TNM staging is CT3 N1 M0 subject to confirmation on ultrasound. And ultrasound can be done very easily, it's not difficult. Clear? Core biopsy, triple assessment done, core biopsy is?
For DCIS.
We do mammography here or what do we do?
Go for mammography for this patient.
Very good. How do you do mammography in a male breast? Easy? They
Painful.
don't understand what is mammography. Why is it different?
Because there is no breast tissue that can be pressed in the
Between the
mammogram.
So what do you do? Ultrasound. Many people do these blunders, dear. And let me tell you, what you don't learn in third year, you will not learn in fourth year. What you don't learn in MBBS, you won't learn in MS. What you don't learn in MS, you won't learn in SRC. What you don't learn in SRC, you will never learn. And you'll remain ignorant all your life. So node positive axilla, what should we do? What should we have management?
Sir, if it has come out to be DCIS, we have to check for the axillary lymph node sampling by ultrasound guided FNAC
How does
also.
How does it change your approach? Yes?
The DCIS may be a false negative report, and we have
False positive. What is DCIS?
we have not taken from the
Representative area. So it should be a guided core biopsy and an FNAC from the ultrasound just to confirm it. Because DCIS is usually not associated with lymph node metastasis. So we are concerned. Treatment.
now for male.
What is the usual pattern of male cancer breast? Biological. They are positive or negative?
So negative. ERPR.
They are positive. That's the mistake you made. You thought I'll say negative because they are bad cancers, but they are positive. ERPR positive cancers you get in males commonly. But you need to know based on core biopsy. Clear?
Yes, sir.
So what is the ERPR status?
So not done. DCIS is the reports. They've not mentioned the
So
IHC.
written DCIS, fragmented biopsy, invasive breast carcinoma cannot be ruled out.
Patient should be managed by surgery and we should do a modified radical mastectomy without any confusion in this case. And you'll find that histopathology would come out to be core invasive breast carcinoma. And usually they are ERPR positive and HER2 negative cases, but we never know. Okay.
We can also go for some genetic testing in this patient because male breast cancer is commonly associated with
Excellent
BRCA2.
point. Why?
Because it is
Which one?
BRCA2 mutation.
BRCA2. So which all genes you will study in addition?
Sir, BRCA2. Along with that, we can go for P53, STK11, P10, but mainly BRCA2 is.
PAL-B, P10, BRCA2. And once again BRCA1 done, there is no harm in it, but BRCA2 ke saath, what are the other cancers you look for?
Sir, colon and prostate cancer is associated with.
And pancreatic cancer. So pancreatic, colon and
Male breast cancer and
Prostate.
prostatic cancer.
male breast cancer is already there. So must have a serum PSA. So you know the working now. वरना क्या ब्रेस्ट कैंसर का पेशेंट है इसका मैस्टेक्टमी MRM कर दो बस हो गया तो क्या पेशेंट कहीं भी गया it is
Usually, sir, in the BRCA2 positive patient, the ISC would be ERPR positive.
that's why we BRCA2 positive cases have ERPR positivity. BRCA1 has ERPR negative. Triple negative is common there. So he will be put on hormone therapy subsequently. The drug that we use in these patients is tamoxifen. That is what we go for. That's the management.